So we're here just to do a general overview of direct methodologies or direct barrier methodologies. Now before we do that, we want to take a brief moment and essentially distinguish between end range and the direct barrier. So if we take a common hip internal rotation, external rotation at 90 degrees of hip flexion, right? So internal rotation, external rotation, both of those would essentially be passive end ranges. Those passive end ranges will have a feeling of tension, a feeling of tightness. That does not necessarily mean that it's the direct barrier. The direct barrier is essentially the place where, given normal biomechanics, given free range of motion, both sides, when compared to the other side of the patient, one side, so one hip, so if I test this hip in internal rotation, it doesn't like to go particularly far, so we can pretend that this is as far as it goes, and the other one has a much freer range, so the left one has a much freer range. Then what we're saying is there is restriction on the right hip in internal rotation, so it likes to externally rotate as a comparative sense within essentially osteopathic terminology. Now, when we identify which side of the body when compared to the other one has a restriction, when we go to that motion, we will call it the direct barrier. And often, the feeling that we get will mimic somewhat an end range feel. And that's not what we're looking for. So if we're talking about something such as assessment, so you look at the assessment concept videos that we've done in the past, macro identifies micro. So we would have our algorithm, we'd have our clear-cut algorithm, we'd test the patient, we'd identify which side of the body had more of a challenge with motion. So if we just do something as simple as a straight leg raise, we check here, nothing particularly poor there. We check here, and when we compare them, right, like in force, but when we compare them, from my vantage point, it seems that there's a little bit more of a challenge with the left leg. Now, am I perfectly correct on that under the circumstances? Not necessarily, because of the angle of the camera and whatnot. However, what we would want to do is identify between the two sides which one has the problem, and in this case, what we could say is that it's the left leg in a straight leg raise. All right, that's as far as we can really go with that without further investigation. Now again, we've distinguished between the direct barrier and end range. And the way that we did that as a demonstration is to show you that the left leg on the straight leg raise showed slightly more tension, slightly more resistance. That doesn't mean there's necessarily a problem, it just means it shows there's slightly more resistance in that test. Okay? So end range is expected anatomical end range. Direct barrier is when there's tension or an end range feel somewhat short of what an expected anatomical end range would be. That being said, when we're looking at direct methodologies, we can have an overarching concept for them. And what we'll do, instead of talking about techniques or systems, so we're not going to necessarily talk about myofascial release per se, we're not necessarily going to talk about muscle injury per se as systems, we're not necessarily going to talk about any of that, we'll speak about it in an overarching sense. So, as we've spoken about many times, having your hold, setting your hold, identifying your direct barrier, right? You go to your direct barrier once you've assessed, so you identify. So I've got my hold here. Now if I'm holding here, then what we have, if I wait, it's myofascial release. Now, as I said, we're not necessarily talking about the systems per se, but as far as a possible mechanism, when we're holding, right, when we just hold onto a barrier, be it direct or indirect, some people will speak about myofascial release, direct and indirect. What we can say from an observational standpoint is that when we hold and wait, direct or indirect, so in this case we could pretend I'm holding direct, what we get is some form of loosening. Now there are people who would argue that that's a neurological phenomena, some people would argue that it's a histological phenomena. The histological realm doesn't, or histological explanation doesn't have as much credibility because the amount of force it would take to deform fascial tissues is very high. It's unlikely we're producing those when using hands-on methodologies. That being said, we hold and we wait and we wait and we wait on the direct barrier. Now most people will call that myofascial release. Some people may disagree. Again, there may be a neurological phenomenon with that waiting. So when we're looking at working direct, we can have a long hold or a relatively long hold. We don't need to name that one system or another, but we can say there's a long hold, right? So that's a patient passive methodology. Now what we can do is we can use contraction, patient contraction. Now some people will tell you that it has to be this precise contraction in the perfect direction with the perfect muscle. I would suggest to you that that's not likely to happen, partially because of communication issues, partially because of learned motor patterns in a patient, also confusion. All of those things are going to be barriers to application. But if I'm here and what I tell the patient to do is I say, I'm going to show them, as far as communication, I basically want you to wiggle your leg back and forth like this. Okay, when I hold it still, we're not going to let it move, and don't push too hard. Okay, so I hold here, so I just wiggle your leg back and forth. Not so fast, a little smoother, a little slower. Okay, and then relax. Okay, that patient active approach, some people will tell you it's making the perfect muscle relax. What I would suggest to you is that muscular firing on and off, muscle on, muscle off, multiple muscles in a region on, multiple muscles off, gives you the opportunity to essentially have some neurological response, be it on muscle spindles, be it on alpha motor neurons, gamma motor neurons. It doesn't necessarily matter because we can't pick that out. We're working on the outside. What we can say is that when the patient either contracts into resistance or against resistance, or in both directions, we have a patient active approach which will have muscles and nerves essentially interfacing. You have the muscles on and off. So as far as direct methodologies, you can either have your long hold, you can have your patient active on off for a neurological response of some sort that we can't prove particularly accurately in the moment. And then the other thing we can do is essentially articulation, so rhythmic motion. Some people would speak to you and suggest that the rhythmic motion is also a neurological phenomenon. Some people will talk about being on and off barriers, so direct and indirect. Now to go indirect, you'd actually have to go to the E's. Often in articulation, as I'm showing you this rhythmic articulation, you're nowhere near the indirect barrier. So if we say the indirect barrier is over here, the indirect E's is over here, and the direct is over here, my articulation is going to be here. But then you'll get discussion of kind of on and off of the direct barrier, right? So mechanistically, there is at least the opportunity to suggest that there's a neurological phenomenon here on the sensory side. Do I agree with that completely? No, not absolutely completely. I'm not 100% sure as to what specific mechanisms at play or multiple mechanisms. However, what I do know is that when I'm going direct, often coming on and off of that direct barrier creates the desired result of more motion in the direct range or into the direct barrier. So instead of being short of physiological range or short of anatomical end range, I can approach it better, and there's better motion characteristics for the patient. So that being said, our overarching concept here, when you're going direct, you either have a long hold, you have patient active approach on and off, or you have kind of an articular rhythmic approach. All three of those are applicable into the direct barrier. You could essentially do the same thing in the direct barrier the indirect barrier rather, please excuse me for skipping over my words or fumbling over my words. You could also do a very similar overarching concept with indirect. However, in this case we're talking about direct, so you have your long hold, right? Some people will say MFR, myofascial release, some people will say there's a neurological phenomenon on the sensory side. I'm not concerned which one it is, I'm just going to suggest to you that the long hold will sometimes work, patient active approach, so contraction, whether it's an extremely precise feather edge contraction or just kind of a general contraction in both directions, doesn't really matter. It seems to create some form of response. Often we may be somewhat on the right track to suggest that that's a neurological phenomenon, and then you have your articulation, so your rhythmic on and off of the direct barrier. All three of those used in sequence could be useful if you're not sure which one to do, or over time if you understand and you've used all of those on purpose, so you've done your long hold and you've seen whether or not that helps the motion dysfunction you found, and it didn't, then you do your patient active approach, your on-off contractions, and that didn't work, and then you do your rhythmic application, and that does work. Then what you do over time, regardless of which one works or which one doesn't, if you go in a purposeful sequence, what you will end up learning is which ones work in which situations, and you'll develop what we can call intuition. It's not necessarily intuition, it's pattern recognition built over time that you don't access consciously and purposely, but you recognize the pattern, so you go there quicker, you almost shortcut steps. Regardless of all of that, those are the three main categories of direct work or working on the direct barrier: the long hold, the patient active contractions, and the rhythmic application or the on and off of direct barrier. You could call it articulation as well.